The Knee Gurus, the latest research and advice from industry experts for best practice management on knee injuries and pain. Here's your host, Bevan Colless.
Welcome back to the Knee Gurus. I'm your host, Bevan Colless from Asia Physio, and we are very lucky to have with us today, back for the second time, friend of the pod, Stephanie Filbay, Dr. Stephanie Filbay. Stephanie was our first ever guest on the pod in episode 2 back in November 2021, where we discussed evidence-based ACL management and non-surgical versus surgical ACL management. And since then, Stephanie has been a titled researcher on the newly published cross-bracing protocol, which is a research project on a novel bracing technique or protocol that is designed to encourage ACL healing. So as an introduction, Stephanie is a physiotherapy graduate from La Trobe University in Melbourne in 2010, and she was awarded her PhD in 2016 on longer-term outcomes after ACL injuries with a specific focus on quality of life. Stephanie was also based in Oxford University in the UK for some time, where she was a senior researcher in orthopedics, rheumatology and musculoskeletal sciences. She's currently a research associate and NHMRC fellow at the University of Melbourne, and her research is focusing on optimizing people's outcome with ACL injuries and knee osteoarthritis, and now ACL healing. Her papers have been featured in many of the world's leading medical journals, including the British Journal of Sports Medicine, Journal of Orthopedic Sports Physical Therapy, American Journal of Sports Medicine, Scandinavian Journal of Medicine and Science in Sports, and Orthopedic Journal of Sports Medicine, and more. So I think it's probably fair to say Stephanie is one of the world's most prolific authors of studies on the anterior cruciate ligament, particularly when it comes to studies on the comparison of surgery versus non-surgical management of ACLs. For various reasons, the vast majority of research into ACL management is focused on surgery types, such as comparing graft techniques to one another, failure rates between different graft techniques, and return to sports rates post-operative. But the studies for non-surgical management to surgical management are still in the minority, or still quite reasonably uncommon. And now we have this new field of ACL healing, which Stephanie is a lead researcher in. So I hope I don't make Stephanie blush, but I'm not the only one. It's called Stephanie, the rockstar ACL researcher. And we're very happy and privileged to have Stephanie back here. So Stephanie, thanks very much for joining us.
Thanks, Bevan. Really happy to be here again to discuss our latest research around ACL healing.
Great. So can you, for people who haven't listened to one of your other podcast interviews, can you just fill in our listeners on how you became so involved in ACL research? What was your journey like?
Sure. Yeah. So I'm a bit of a what they'd call a patient researcher, because I've been through my own sort of ACL journey before doing my PhD and going into research in this area. It was actually while studying physiotherapy. So I was just turned 18 when I first ruptured my ACL and had ACL reconstruction. I then took quite a while, and I think I had some complications from the surgery in terms of a cyclops lesion. And so I had a follow-up surgery, and then it took me a while to return back to soccer, which I was playing at the time, before I tore the graft and went and had revision surgery. There was another complication of that surgery, in that the screw had unscrewed itself and had to be removed. Then I got back to soccer again and re-ruptured that graft. So I didn't have a third surgery at that point. So now I'm ACL deficient in one knee, and I developed osteoarthritis, within 10 years of that first injury. So I now live with sort of a painful, swollen, unstable knee, I suppose. So I've had my own journey, both as a patient, as a researcher, and as well as a physiotherapist managing patients with ACL injury.
And have you back playing soccer now, or have you retired? Or
Well, funny enough, after the last injury, I decided to stop playing soccer and took up Aussie rules football instead.
oh,
It's a bit of a joke, really. It's not like yes, but funny enough, it does feel a little safer because you don't have as many people kicking your legs, not as much force through the shins and the knee. It's more, uh, body level contact. So, you know,
yep, yep. Okay. And can you tell us a little bit about how you became involved with this new study on the cross bracing protocol?
yeah, sure. So Tom Cross reached out to me some years ago now. Tom Cross is the sports doctor who's managed now over 430 patients in clinical practice with the bracing protocol. His father, Merv Cross, who's a very experienced orthopedic surgeon, it was his initial idea to brace someone in 90-degree flexion. So together they initially developed the protocol. And there was a group of multidisciplinary clinicians that had been managing patients in clinical practice. So they reached out to me as a researcher and sort of said, where are we at and how can we design a study to publish the findings in terms of what they were seeing in clinical practice. So I then helped to design a study and get ethics approval and consent the participants to use the data, analyze that data and write that up for publication. So now we've been collaborating for some time and we're working on a range of other studies as well. So that's a team of, including a sports doctor, physios, radiologists, a biomedical engineer, an orthopedic surgeon. So it's quite a multidisciplinary group.
And the same group that published the recent study in the British Journal of Sports Medicine is sort of ongoing, you mean?
Yeah, I think there's a core group who are largely involved, and then a wider group, including physios that have all been involved in the management of the initial patients and helping to develop, the physio rehab-based protocol, for example.
Yeah. And so the study that was published recently is what's known as a case series. So for our listeners who might not be familiar with research, can you explain what a case series is and compare it with a randomized control trial, and maybe explain a little bit about double-blinded studies and peer review and these terms that I know researchers kind of use quite freely, but maybe the general public doesn't understand so much?
Sure. So a case series or a retrospective case series, but we won't go into too much detail around that. But the design of this study was, as I mentioned, these patients had been managed in the course of clinical practice.
Yep.
And their data had been collected, at standard time points, so 3 months, 6 months, 12 months. But when they went and had treatment with the bracing protocol, they weren't entering a research study at that point in time. So we came along and asked them after the fact, actually, can we use this data for a research study? And then they consented and we extracted the data. So that design is a retrospective case series. Retrospective because we go back in time and consent them, compared to you could have a prospective study, which means that at that point in management, they're signing up for a research study. A clinical trial is the most robust design that we have to compare two treatments or two or more treatments. And it's robust because people are randomized based on chance alone. They're randomly allocated to one of two treatments at baseline. And what that does is it minimizes bias, like selection bias and differences in patient characteristics that you'll typically see from a non-randomized study that compares two treatments. So an RCT or a clinical trial is the best design that we have to determine if one treatment's similar or better to another treatment.
Okay. And what about what does a double-blinded study mean?
So double-blinded, so if it was single-blinded, for example, means potentially the patients don't know which treatment group they've received or which treatment they've received. A double blinded would mean both the patient and the treating clinician or the researchers also unaware of the treatment that they've received. So you can imagine that that's pretty hard to do when it comes to, say, ACL surgery compared to non-surgery.
Yes.
Because there's a lot of factors, there's a lot of clues that give away the kind of treatment you've had. In saying that, there have been some what we call placebo surgical trials. So, for example, one on meniscus injury where that was double blinded, where they make the incision, and in one of those groups they do surgery to the meniscus, and in the other they kind of have a little play around in there with the instruments and sew them back up without actually touching the meniscus. Right. In that design, you can actually blind, the treating clinicians, the researchers, and the patients to the actual treatment received. But it's pretty challenging to do.
Yes. And so this study was a case series. Is there any chance of producing a randomized control trial similar with a bracing protocol? Is that something that's in the works or being discussed?
Yeah, absolutely. So we've designed that, applied for funding. So we've got 2 applications in at the moment to hopefully get a randomized controlled trial funded, a large multi-site trial. The initial idea is to compare ACL reconstruction with the cross-bracing protocol. We'd like to run a second trial where we're comparing the bracing protocol to non-surgical management, but I think those trials are quite distinct, particularly if performed in Australia. One would be in the private sector and the other in the public sector. So fingers crossed we get that funded and we can start that trial early next year. We'll have to wait on the outcomes of that funding.
Yeah, and they're now producing more kind of easier to live with bracing protocols. I understand they're calling it a modified cross bracing protocol. Is that an area of future study that you think, or do you think the researchers are quite set on this 90 degrees being really critical to ACL healing?
Yeah, so I think the real world when it comes to clinical practice looks quite differently from designing a robust research study. And so they don't always necessarily align. Yeah. In clinical practice, it's about personalising the treatment for the individual patient so they can have the best outcome. So that doesn't always mean something standardised that's the same recipe for every person. So I know now Tom's done a number of different modifications in line with people's preferences or lifestyle or particular presentation. He's learned a lot of lessons now in over 7 years of managing these people. So there has been a number of different modifications for some people. In terms of a research, first we need to know, we need a sort of a standard comparison between, let's say, the 90 degrees standardized protocol, but there's so much scope to explore variations of that, What about bracing at a different angle? What about bracing for a shorter amount of time? There's a lot of different adaptations and further research that could be conducted, but I think we need to start somewhere, and the cleanest way to explore that is for it to be a standard protocol initially with the research.
Yep. I guess it'd be great one day to be able to look at an MRI and quickly be able to have a pretty good idea whether somebody was not only a good candidate for the cross-bracing protocol, but perhaps even a more appropriate for a modified bracing protocol, or someone whose chances of healing are quite low. But that's probably some way off in the future, I imagine.
I mean, we're already doing it in clinical practice, but the research is lagging behind. We've designed a study to look at predictors of ideal healing with the bracing protocol based on what we're seeing on baseline MRI. So we're seeing lots of strong patterns and trends in clinical practice, but we need the research to back up what it is that we're seeing in clinical practice. But in terms of patient decision-making, so let's say Tom Cross in his clinical practice, he's now making decisions based on lessons learned, after managing these people for 7 years with the bracing protocol. So, for example, if you want to know some examples in terms of modification, so now with a full MCL rupture, some will often give a modified protocol because they're more likely to be quite stiff when the brace comes off. In saying that, that doesn't appear to influence healing rates, and we had half of people had MCL injuries from that first 80, from that published paper, but that's a consideration. Another consideration is, some people say have kids at home that they need to look after and they can't be braced at 90 degrees. So there's been a lot of exceptions where we've thought, okay, we don't have the evidence for this, but let's try doing this altered protocol or a more rapid protocol over 6 weeks, say, instead of 12 weeks. And some people have experienced, really high grades of healing with modified protocols as well. And the other would be the more minimally injured ACLs. So the ones that are verging on a partial rupture or a high grade, or those where, the rupture's quite clean and there's this minimal gap distance between the ACL. There's no avulsion. So those people may be more likely to heal with a shorter bracing time. So there's a lot of different considerations, I think, and it really depends on the individual patient's lifestyle in terms of how burdensome is it. And it really is that initial 4 weeks when you're braced at 90. I think after then having the weekly increments where you've got greater range of motion, you're doing more rehab, and you see that progress at weekly increments. I think that's less challenging and more motivating. But those initial 4 weeks can be quite challenging when braced at 90 degrees.
So I guess the theory by the sounds of it is the more severe the rupture or the more complete and I guess slightly further away the stumps may be from one another, the more strict you should be with the adherence to 90 degrees. Is that the hypothesis you'd say?
Yeah. So what we're seeing in terms of, so there seems to be, a continuum of healing, if you will. So the best case heal is a normal appearance ACL. So it appears on MRI as if it was never injured. A step down from that would be normal alignment, normal tautness or tightness, if you will, but slightly thicker than before. Slightly worst case again is if it's thinned along a portion of the ACL or it presents with a bit of a sag or it's elongated. Then we see a variety of people who it hasn't healed, but it may have fused or healed to the PCL or the knee capsule. We don't know if that may provide some additional stability compared to a torn ACL, but we don't really understand that yet. So in terms of the pattern of injuries, it seems to potentially relate to the kind of grade ACL heal that you may be likely to experience. So in saying that, if it's pulled off the bone where it attaches to the thigh bone, the femur or the tibia, it may be less likely to have an ideal heel. If the bottom half of the ACL is flipped, so that fibers aren't standing up, they're kind of flipped over or outside the intercondylar notch, may be less likely to experience the ideal heel. And then the gap distance as well, when you see a much wider gap distance or part of the ACL is retracted compared to when it's more thin gap distance. Another thing that may be important is the time in which you brace after injury. So we think there may be a period where it's too late to kind of benefit from that reduction and immobilization aspect. So,
and I've heard around about 18 days is about the latest that the practitioners want to include people in this study. Is that about right?
18 days. I'm not sure. Yeah, that's quite specific, but yeah. So initially for that first 80, we drew the line at 1 month, but most of them were braced within 2 weeks. Yep. There's been exceptions again, where it's been explained to someone, look, we think this is too late, but they said, I want to try it anyway, after a month, and they've healed. So it's not as if it's not a black and white, there's no precise time point, and we're trying to kind of understand how we may be able to inform that decision making a little better. But we think earlier the better. And in some cases, you can see that half of the ACL is retracted and capped over. It's kind of rounded, and that may be too late at that stage. So maybe the signs on MRI that we can use in the future to inform if it's too late to benefit from that bracing.
And this level of detail in radiology interpretation, I would imagine, is quite rare. Often you'll get MRI reports with just a one-line description saying the ACL's ruptured. But we're going into quite in-depth descriptions of the different types of ruptures, the areas of ruptures, and distance the stump. So if somebody had ruptured their ACL and they're trying to work out if they're a candidate for the cross bracing protocol, how do they do that? Do you think your local MRI center that you just sort of your local GP recommends are able to provide that level of detail, or do they really need to search out a specialist in ACL MRI interpretation?
Yeah, that's a really good question. I think at the moment, the typical radiologist won't provide that level of detail because it isn't current practice. We are developing a new guideline and criteria around how to report on these baseline MRIs based on the variables that seem to be important in relation to healing. So hopefully we'll have that published. It's not too far away, and that might help. But at the moment, because people really didn't think healing was possible or frequent for some time, so it wasn't something that was a focus on in reporting both injury and outcomes as well. So hopefully that will change moving forward. But at the moment, it will be a bit challenging. Even a sports doctor may not, know exactly what it is to look out for. And it can be quite subjective. So it would help to have training and experience when it comes to reading baseline MRIs for ACL injury as well. So that's not very helpful, is it? But at the moment, on the bracing protocol pathway, Tom has been doing a lot of the reading with radiologists who are also involved in the management. And he's become quite an expert in reading them, but he's only one person and only has so much time. So we definitely need to train more people to read the baseline MRIs.
Yeah, for sure. And just briefly, could you run us through the results that have been published today? I know we've had 90% healing rate in the first study of 8 that's been published of 80 people, but you said they're now up to 430. Could you give us a spoiler on if that rate has continued to go on, or is that still sort of top secret information?
Yeah, so we're in the process of finalising the consent for those last patients to use their data and to publish and analyse that data. We do have data for the next, I believe it's around 287 who have reached the 3 months, and the healing rate is, using that same criteria, is more like 95%. And the reason that's slightly higher is because, as we'll be reporting in the next publication, some of the clinical judgment has changed over time, where Tom may become a bit more selective, trying to sort of give people the greatest chance of that ideal heal. So if, for example, if someone presented with a partial avulsion off the bone and quite disrupted fibers, he would probably have said, look, based on my experience, I don't think you have a very good chance of getting a good heal with the bracing protocol. Whereas in those early days, or the first 80, people weren't told that. So it may become a little bit more selective over time, which looks like it's pushing that percentage higher than 90%.
Yep. Okay. Oh, well, it's still pretty remarkable rates considering as to what the ACL can't heal at all, and now we're looking at 95% success. It's amazing, really. So, Stephanie, I know you've done a lot of analysing of other people's studies, literature reviews and systematic reviews and the like. If you were an outsider analysing the cross-bracing protocol, what would you say that the sort of strengths and weaknesses of the study are? How would you be critical of it? I guess there's still a lot of resistance out there to this belief that the ACL can fully heal full ruptures. And so what would you say the strengths and weaknesses of the study are?
Yeah, so there's inherent weaknesses with a design, as I explained in the case series design. And some of those are obviously, firstly, that we don't have a comparison group. There's no comparison group in this research design. Secondly, patients weren't blinded to their healing outcome. So at 3 months when they had an MRI, because it was part of clinical practice, it wasn't designed as a study from the outset. So they received feedback based on what they were seeing on MRI. So some people were told, it looks like you've had some healing, but it's not great. It's got a sag, or it's thinner. Or maybe they were told, this looks really good. This is what we consider a really good heal. So your perception of how your ACL heals may influence the way that you perceive and report your knee outcomes in the future.
Right.
So that could be a limitation here. In saying that, the other study that we published that I spoke about last time, the Canoon trial, a strength of that one was that people were blinded to their healing status. It's not something that was looked at by the researchers at the time, the clinicians, or the patients. And we found that those with healing reported better patient outcomes than those who had surgery, and better outcomes than those with no healing. So that kind of, I often combine the two studies in terms of lessons that we can be learned collectively from both research together. What else? In terms of a strength was that all 80 patients, the first 80, all of them who were treated with the bracing protocol provided consent and participated in the study. So we don't have any missing data. We've got data from everyone. So that's a strength.
Yep.
What else? I mean, the protocol develops over time. So those very first people 7 years ago that tried the brace, the information they received and wasn't as developed as maybe the 40th, 50th, 60th, 70th person, because it takes time over time to develop these things as well. So that'd be some of the limitations. I think the limitations in the design is warranted by the novelty of the research. So because it hadn't been done before, that's a real strength of the research. So it's just really important that you interpret it, taking into consideration limitations in design, which I think we've done in terms of the write-up of the results in the paper. So we've made that quite clear, that further research is needed, including clinical trials.
Yep. Okay, great. So we're still looking at this push towards a shared decision-making model when it comes to a lot of decisions surrounding health care, but particularly relevant in ACL management. And I know it's sort of speculation and without offering specific or medical advice to any person in particular, but some of our listeners might have sustained a recent full rupture of an ACL. And so if we can just sort of take an imaginary patient who's sort of a few days post full ACL rupture, so it's a proximal non-avulsion rupture, which means it's not off the bone. It's towards the femur end of the ACL. Nothing else is damaged inside the knee. And the MRI shows that the stumps are quite close together. Could you let us know what sort of patient characteristics as a generalization might be a candidate for early surgery? Say someone that, I don't know, would there be anyone you would say that would be well advised just to go in and have surgery quickly and with that sort of clinical presentation?
With that clinical presentation, that particular, so isolated, no meniscal injury.
Yeah.
The only probably reason why I would think someone may choose that treatment option based on what the evidence shows is if for some reason, so there's a bit of uncertainty in terms of the timeline with any non-operative management. So if you're successful, you can typically return to sport faster than if you have surgery. But there's always a chance that you'll go on to be recommended surgery despite trying non-surgical treatment first. So that can push back your treatment recovery because you then have to have surgery and wait typically 12 months post-surgery to return. So depending on when you make that delayed decision, it could push everything back by, let's say, 3 months or 6 months longer than if you were to have surgery straight away. So it's a bit of a gamble, non-surgical management. I may be able to return faster than surgery, but there's also a chance of it being longer than surgery. So let's say you're an elite athlete who in 13 months' time has an Olympic Games or a grand final or something really important to compete in, or even the start of the season. Considering that timeline, you may move towards actually, I don't want to take the risk that maybe I could possibly require delayed surgery and have to miss that event. I'd rather try surgery and have a greater chance of making that time point. Does that make sense?
Yep.
In saying that, of course, it's not guaranteed that you return to sport after surgery at all. Only 55% of people get back to competitive sport, but often that expectation isn't held by the patient. Most patients expect that they will return to sport. So that's one consideration is around timeline.
Yeah, and I guess if it's a club paying somebody's salary, then they're highly motivated to choose the fastest route back, or may, I guess, see surgery as a more assured return to sport pathway, I guess.
Yeah, which it isn't. So it's not. So we're actually doing a systematic review and meta-analysis at the moment, and it shows no difference in return to sport rates whether you have surgery or not. And that no difference is even considering 4 of the studies in this review actually recommended to the non-surgical group that they don't return to competitive sport. Even with that advice, the same percentage return with surgery or without. So it is a misconception that you're more likely to return to sport with surgery. But it's certainly one that's a really common belief that's, I think, held by many physios, clinicians, and patients, and as well as sporting teams, coaches, and that sort of thing.
Yeah, I have just in discussions with fellow healthcare professionals and the general public, be a little bit dismissive of a bracing protocol when it comes to elite athletes by just saying, oh, well, if you're paying them such a big salary, you're just going to go for surgery. But you're saying you can see a time where a bracing protocol or conservative non-surgical management is appropriate for elite professional athletes as well as the general public.
Yeah, absolutely. And I don't see why it wouldn't be. It seems like if there's going to be ACL healing, it's apparent as early as 3 months after injury on MRI. So we found that in both studies. And that's often the period of time that's also recommended if you just have rehab without bracing. At around 3 months, if you have ongoing instability, then maybe surgery is a good option for you. So we're really then talking about 3 months, 3 months to potentially avoid surgery. You will always have the option of having surgery if you have non-surgical treatment first. But once you have surgery, you can never go back, obviously. The ACL is removed. So you'll never have a chance at healing. You'll never have a chance of, recovery through a non-surgical pathway. So that's something to be aware of. It's really that extra burden of, in this case, bracing, because it's burdensome for especially the first 4 weeks.
Yes.
Yeah. But then again, post-surgery, for the first 4 weeks post-surgery, you're usually pretty immobile. There's a lot of pain and swelling.
Yeah. And would you say there's a stereotypical characteristic of patient who you might say, oh, look, the cross bracing protocol is too extreme. The juice is not worth the squeeze. You probably, uh, for you to go through such a long period of non-weight bearing and inconvenience, I wouldn't recommend you do that. And but by the same token, I wouldn't recommend you have the surgery and just sort of go to your physio and start strengthening and working on your range of motion and choose that treatment pathway. What sort of person do you think that would be advisable for, or someone with the same clinical presentation?
Yeah, so it's largely lifestyle factors. So let's say someone is a tradie, they have to be active, they can't afford to take any time off work, they run their own business, have to pay the mortgage, I don't know, and that's not an option to be out of action for 4 weeks, let's say, or longer. For that person, so where you want the inconvenience and burden and period of inactivity to be minimized, just rehab may be a good treatment choice because you're not immobilized in a brace and you don't have to experience the acute post-operative impacts of surgery, which can be quite debilitating for a few months. So that would be one instance. Another one is, similarly at carer, if they've got caring responsibilities or young kids with no one to help out, have to drive them here and there, they can't be out of action. So that's another situation where you might consider rehab only. We don't know yet, but as mentioned in the Canoon trial, 1 in 3 people who start rehab only experience ACL healing. We just don't quite know yet how to tell which people will experience healing with rehab only. And it could be, it makes sense hypothetically that it could be, for example, the case you're describing there where it's quite a clean rupture, not pulled off the bone, fibers are nice and aligned. And maybe these type of presentations that have a high likelihood of healing even without a brace. We don't yet know, but it's possible. So hopefully we have more information in the future to inform that kind of decision.
And what about the age of the patient? Do you think that plays a role in deciding a treatment pathway? Have you noticed that younger people, just through having a higher healing ability through youth, are having better healing rates, or older people who don't have such high future sporting goals involving pivoting? Is it still worth those people going through the cross bracing protocol, would you say?
Compared to rehab alone, I mean, if your chances of healing increase, let's say from 30% to 90% with a brace, is that worthwhile? And that's something that information you can give to patients and let them make an informed decision, understanding the extra burden that's involved with having a brace compared to, say, no brace, and let them make that decision, I suppose. But, it's been another common belief held by physios and the general public is if you're older and if you don't want to return to sport, then you can probably get away without surgery. You probably don't need surgery. So there's no evidence to support this because, as I mentioned, return to sport rates aren't different. Re-injury rates aren't different on average. So there isn't any kind of evidence to support that belief. In saying that, some people will be managed with rehab. A portion of people will have, let's say, ongoing knee instability, at which case that delayed surgery is recommended.
Yep.
So I guess at that point, you may have people who really don't want surgery and say, look, I'm retired from sport. I'm happy just running or jogging. My knee doesn't give way. I think I can live with this level of knee function. So that should be factored into the decision making at that point, I think. But even those, older adults, irrespective of if they want to return to sport or not, could have, I think knee function is important no matter what you're doing, really. You need a functioning knee, even carrying groceries home or jumping in and out of the car or carrying small children around, even if you're not high level of sport. everyone aims to regain knee function if possible. So I think, at the moment, it's not clear which treatment will give you the highest likelihood of regaining knee function. That's why we need a clinical trial to look at this.
Yep. Okay. Yeah, it's interesting. Yeah, it really, it's quite amazing how we've gotten so much so wrong with ACL management. In fact, if you look through the key tenets of beliefs of ACL management and ACL ruptures, we've probably got a lot more wrong than we have right. If you can just kind of agree or disagree on a few of the key points, we've been told that ACL reconstruction reduces the chance of earlier osteoarthritis, but that is incorrect. Would I be correct to say?
Yeah, it may actually increase the chance of early osteoarthritis, as we see on X-ray anyway.
And we've been told that it's going to reduce your chance of future meniscus tears. What would you say to that in a nutshell?
So there's recent literature reviews that found there's no evidence to show that at the moment. The evidence is low quality and we do need further research, but there's certainly no evidence to support that belief, no.
And for non-surgical management versus ACL reconstruction, will it reduce your chance of returning to pivoting sports? Because a lot of people will say, well, if you want to go back to skiing or playing football, you need to have an ACL reconstruction.
No, on average, there's no difference in return to sport rates.
We've also been told from a physio perspective, and we still have a lot of surgeons lecture us on this, that open chain knee exercises, that's your typical knee extension or any sort of exercise where you've got a weight below your knee and your foot is hanging in the air. We've been told that that should be avoided post-op ACL care. What would you say about that?
So the consensus now is that it's safe to do open kinetic chain. So we've gone sort of full circle there. Yep.
Yeah, and we've also been told that the ACL has no blood supply.
Yep. Apparently, it does have a blood supply.
Okay.
Yes.
We've also been told that the ACL doesn't have the ability to heal. Can we pretty much conclusively say that the ACL can heal? I've heard some surgeon friends of mine say that they still don't believe the ACL can heal if the envelope or the sort of sheath or sac that covers the ligament is fully ruptured, that it can't, that they still can't come back, or that the ACL can only heal by binding onto the PCL or something. But do you think there's enough evidence now to conclusively say that yes, even full ruptures, including the envelope surrounding the ACL, can knit back together if they've been fully torn?
I think so. I think it's quite funny, like the hesitancy by some people in using the word heal when it comes to an ACL rupture. But if we take any other tissue in the body or any other ligament and it's completely ruptured with a gap and then it's re-imaged and it's rejoined the fibers with normal alignment, that would be considered healed in terms of the terminology of what we mean by healed. But when it comes to the ACL, it's like, oh, I don't know about that. It could be, it could be some other form of tissue, or what we're seeing on MRI isn't actually healing. So, I mean, I think the best evidence we have at the moment to know whether what we're seeing on MRI is healing is these patient-reported outcomes, which, as I mentioned, in people who weren't aware of their healing status, those with a continuous ACL that had rejoined reported better 2-year outcomes than those who had ACL reconstruction. So those outcomes are sport and recreational function and knee-related quality of life. So if what we're seeing in MRI relates to better function than surgery, I think it does represent healing, and it's associated with some resumption of function. It's likely to vary, as I mentioned, depending on that grade of heal. I don't think it's the same for everyone, but on average, it appears to be better than those who have surgery. And within that average, there will be even better or potentially some worse outcomes as well.
And when I was a student, I was taught that not just the ACL, but all intracapsular ligaments, that's ligaments that begin and end inside a knee joint capsule, they not have good blood supply or no blood supply, but they're also not partially torn. And tearing one of those ligaments is like being pregnant. They've sort of said you can't do it halfway. It's either fully ruptured or fine. Would you say that's been pretty categorically disproven now as well?
Yeah, I actually haven't heard that one, to be honest, because we have, grade 1 and grade 2 ACL tears and partial. We don't have as much research around partial ACL ruptures because they tend to heal. It's not so interesting to research because they don't have such poor outcomes unless they go on to rupture. So, yeah, I mean, I think as with any other ligaments, if there's more tissues intact, it's more likely to heal, and that makes sense, I think. Where there's a grey area in terms of what we can see on MRI is the really high level partials where there may be some fibers still intact, or it could be completely ruptured. I think that can be really hard to tell on MRI. Does it matter if you're going non-surgical treatment or brace? No, I don't think it matters. Does it matter if you're having surgery? I mean, those people will probably be really good candidates for trying non-surgical treatment first to see if that ACL heals, if there's still some ACL fibers intact.
Yeah. Well, and also speculation with all of those points that we've kind of fervently believed over the last 20, 30 years. How do you think we got it so wrong? How did we get to this point where so many of the major truisms we believed of ACL management have been shown to be incorrect? Or how did they become truisms, I guess I'm asking?
Yeah, I mean, it's not unique to ACL. It's actually a lot of orthopedic surgeries are lacking clinical trial evidence to support them. There's recent reviews showing that a lot of the most common orthopedic surgeries don't have any evidence to support their benefit over non-surgical management. So it isn't unique to ACL injury. I think, when we're just comparing the average outcomes to treatment groups, we lose important information around the fact that with any treatment approach, some people will do really well and some people will have poor outcomes.
Yep.
So, before ACL surgery existed, I guess the stories and the narratives you're hearing are around those people that are having poor outcomes, and that can get generalized to everyone. And for those people, surgery is probably a great development, and having that surgery as an option is terrific for those people who won't respond to non-surgical treatment. But I think we've gone a bit excessive in the direction that 90% of people are having reconstruction in Australia, and most people think it's necessary and the best treatment for everyone, and that's not really the case. So I think tying it back and continuing to look at individual patient presentations, and that surgery is staying there as a treatment option, but there may be other options. And as with a lot of surgical procedures, I think they should be considered as the second line treatment. So if there's something you can try first, it's not going to cause you any additional harm, that for a lot of people, that's a really good treatment choice. And then they can go on to have surgery and know that that's recommended for them and it's likely to benefit them. And the reason why it's more expensive, but there's also a whole range of surgical complications and harms that can occur as well. So it isn't, compared to other surgeries, it's a small chance of surgical complications occurring, but they do occur and they can be serious. So we need to factor that into consideration as well.
It just seems like there's so much momentum and sort of weight of public belief as well as healthcare professional belief behind all the current sort of method of managing ACL, that it's going to take a long time to kind of turn the the ship around. What do you sort of see? I know it's a speculation, but what do you see for the future of ACL management and how this cross bracing protocol is going to change things, if it is going to change things at all?
Yeah, I've seen a lot of change since these two papers have been published, even the Canoon paper around healing. There's been, clinical trials showing that reconstruction surgery has no benefit over rehab alone, and they've existed for years, but it hasn't really changed a lot of practice, not in Australia, not in the US, not in the UK, not in Canada. Potentially in Scandinavia, they've taken that evidence on board, but many places of the world haven't. But what I'm seeing since publication around ACL healing is a lot more buy-in from physios and buy-in from patients and the general public. So we've been contacted by hundreds of health practices around the world who want to offer the bracing protocol to patients, and hundreds of patients who've read this evidence and have done their ACL and say, I want to do this treatment approach. So there's something that's more attractive, I think, to this potential for healing than was previously considered when people thought of rehab only. And we thought of rehab only as a way of allowing the body, the mind, the muscles to cope without an ACL. And I think to patients and even to physios, coping without an ACL isn't such an attractive treatment option when patients consider it, fixed with surgery, which we know is not necessarily the case, but that's the perception. So I really see things starting to change. I think the more we learn around healing and the more we tailor our management approach to facilitate the chance for healing, people will start to buy into that treatment pathway and that treatment option, I think. So, and I think that's evidenced by the widespread, attention we've received for this research from media, from stakeholders, industry, patients, and health practices.
Yep. And so, just to wrap things up, you've been very kind with your time, but what sort of advice would you have for somebody who's just ruptured their ACL and they're considering their options? Maybe they're based out of Sydney or Melbourne or one of these key locations where they've got access to people who are familiar with the cross bracing protocol. Sort of advice would you give someone in that situation who's considering their option?
Yeah, so we've done a recent survey of ACL practice in Australia, and in many cases, the advice given from physios, surgeons, sports doctors doesn't align with the evidence when it comes to ACL management options. So that makes it difficult. It's hard to find evidence-based, balanced overviews of treatment options. For that reason, we're designing a patient decision aid, and hopefully that will be, available by the end of this year. And that'll have that aim of providing a balanced overview of the pros and cons, so the individual patient can weigh it up and choose a management option that best works for them. But at the moment, there's certainly experienced physios, great orthopedic surgeons who are able to assist with that decision-making process. But yeah, you need to find a clinician who's aware of the evidence that provides pros and cons of both treatment options. And it is a difficult decision. There's no clear cut. It's not like they won't give you advice and, it turns out that surgery is by far the best treatment option, or the other way around. Yep. If a physio is saying to you, absolutely, rehabilitation's the only option and the best option, you shouldn't consider surgery, then something's probably not quite right there either. So you want to find someone that knows what they're talking about, that can provide a balanced overview of options. And if you're really interested in trying the bracing protocol, so we designed the clinical trial. In an ideal world, I'd like to have clinical trial evidence before I say everyone should be doing this.
Yep.
In saying that, people seem to be doing it anyway because they want to do it. And if they're aware, of the limitations in the current research and still want to try the treatment pathway, there's definitely people now using the cross bracing protocol of course, in Sydney, also in Melbourne, Gold Coast, Perth. So quite a lot of places around Australia. There's also now people in the US and Switzerland and the UK and Canada and other places who are doing the cross bracing protocol as well. So Yeah, you may be able to find it. If you're a month out or 2 months out, I say probably too late and it's probably not worth worrying. In saying that, it's possible that you may be on that continuum to healing just with rehabilitation, having not been braced, because we know 1 in 3 people will experience healing through that pathway as well. So, yeah, does that answer your question? A bit complicated. Yeah. If you're in Sydney or Melbourne, you can definitely find someone. If you're in Sydney based, you can go see Tom and his team, and they've been, as I mentioned, managed over 400 people with the brace. So that's probably the ideal location to be in at the moment if you want to access the treatment.
Yeah, and I guess the other important thing for people to remember is there is that increased DVT risk with the cross bracing protocol. So people shouldn't just sort of buy a knee brace that locks to 90 degrees and go about trying to do it themselves without the assistance of a doctor who can prescribe anticoagulant medication.
Yeah, I'm glad you pointed that out. With anticoagulant medication, we haven't seen any DVTs with that prophylactic medication. But in the early days before that medication was prescribed, 2 people did experience a DVT. Both of those DVTs resolved, but that's why it was introduced to the protocol, and it's really important. So, yeah, we don't want people with acute swelling and inflammation and injury just popping their knee in a 90-degree flexion without considering the DVT risk, and also being screened to ensure you don't have one before you put the brace on. That would not be a good idea either. So, yeah, that's why it's a multidisciplinary management. I think at least as sports physician or some sort of medical doctor to prescribe the DVT and check the DVT risk. And then most of those managements should be able to be performed by an experienced physio from there on in, with the exception of having someone experienced that can read the MRIs as you go. And that may be a sports doctor, could be a specialist physio, or it could be a radiologist that the clinician's working closely with.
Yeah, it'd be great to get the name of some telehealth radiologists who are experts in interpreting ACLs. It's probably a growth area in the future for some of the areas. I think some of the India and Brazil are becoming world leaders in telehealth providers for radiology and MRI research. So perhaps that'll be something people can look for in the future.
Yeah, and if this trial gets funded and we start it next year, one of the first things we'll be doing is creating a suite of free training resources, so e-learning modules for physios and clinicians, so they know how to effectively deliver the cross-bracing protocol. So then if the treatment's found to be more effective than surgery, we can roll that out. We can translate it into different languages and roll that out for free. So that will be a way of both training people, but we could also then capture in a database people that have had that training. So patients know where to go to find someone that's been trained in the bracing protocol as well.
Terrific. Okay, we can probably wind it up there, Stephanie. You've been very kind with your time, and thank you so much for coming on again. And thank you so much for all the terrific work you're doing around ACL. As I mentioned, it's such a exciting time in ACL management, and I just love these topics where long-held beliefs are really being questioned. That just sort of I find that really exciting. Probably the contrarian in me, and so thank you for your for the truth when it comes to knee management, and all the patients that you've helped, I'm sure would like to thank you as well. So thanks very much for your time, Steph.
Thanks for the invitation.
The Knee Gurus, brought to you by Asia Physio, providing world-class physiotherapy care across Asia. Visit our clinics in Tokyo, Singapore, Niseko, Hakuba, Nozawa and Myoko.